As I continue to wait for autopsies to be done, I have to make do with the information that is shared or published in papers. And so, for those who don't quite understand what I'm talking about, is that the gold standard in terms of research is autopsy data, where we look at people who have died, or even biopsies to some degree. We look at people or organs under the microscope and look at the changes that have occurred. This is especially important in the context of a pandemic with a novel virus for which we have used novel technology, and we still have this novel virus in new variant forms circulating. One would think it is absolutely obvious that we need to understand the pathophysiology, because assuming that it is the same as in the first part of the pandemic, when the world had not been intervened with, is illogical to me, because everything was about the immune response. Now that we have changed the immune response, what difference does it make to pathology? That's really where I'm coming from. So, what I'll be talking to you about today is this paper. It's from China, thrombotic microangiopathy with irreversible renal function in CKD following COVID 19. It's a bit of a mouthful, but you'll understand why I've picked this. And as usual, I'll give you some images to help you understand a little bit more about the science and why I am still interested in this question. You have to realize that when it comes to the concept of the COVID storm, spike triggered autoimmune response mechanism, I am looking for strange and unusual responses that people get after they have been reinfected in the context of a highly vaccinated population. And to understand that principle of the storm, I usually use that epoxy resin kind of principle. I'll show it to you here. This is what I mean. You have recurring COVID infection in a population who has been vaccine immune primed. That to me is the perfect situation for creating an epoxy glue where it is far different from one or the other. And that's the premise that I've been going with for many years. And in this case specifically, I'm going to be trying to show you that principle as to why I think this was an example of someone who was vaccinated and then subsequently got reinfected, and the pathology changes to an unusual pattern. So let's go through a few bits with regards to this case. So, this is a patient who had a case of chronic kidney disease, CKD. And it's important to note that he had normal kidney function, renal function, and then he was diagnosed as renal failure after he had coronavirus infection and he had associated thrombotic microangiopathy. And so in this case here, there are a few things about it that I think are very, very important. And I'm usually interested in the presentation because it's a presentation that helps me to understand how will patients present in this context. And in order for somebody to get into a case report, it means it's unusual enough that we haven't seen this kind of presentation. But the inference is a spectrum, meaning that this case is at the far end of the spectrum, but most other people will fall somewhere in the middle, a minor form of this presentation for which it would mean significant rise in kidney disease. So the essence of this case is the fact that he was only 34 years old and he was admitted to hospital because he had blood in his urine for 2 weeks. He felt sick for 5 days and he had shortness of breath for 3 days. I'll highlight that. So it's important to note that he didn't have any significant past medical history when this started, and he was found to have protein in his urine and an elevated blood pressure. Now, he had suffered from COVID-19 2 weeks before and was not taking any medication. Okay. So the other thing that you have to notice is that 2 weeks before, he had a normal COVID infection, no problems, no symptoms, and then he admits to hospital with blood in his urine, nausea, and shortness of breath. And this is the point that I'm making to people, is that if you imagine that they didn't know that he had COVID, so he just felt a little bit unwell 2 weeks ago, had a bit of a cough, a bit of a temperature, lasted a day, felt a bit fatigued, no problems, he forgot about it. And then he presented to hospital with those symptoms. If you were not looking for COVID, you would not have seen it. This is the really subtle but important point that I think should become a part of clinical assessment. Every single patient who is not typical, you want to know if in the 2 weeks to a month before they presented with unusual patterns, did they have symptoms of a viral infection? And because nobody is taking it seriously, nobody would probably have checked. So the patient would have no idea. Now, in order to understand the significance and the seriousness of this kind of presentation, you have to look at what happened. Remember, he's only 34 years old. What they found is that he had symptoms of acute left heart failure. Okay. His blood pressure was up. And then he also had evidence of a viral pneumonia combined with fluid on the lungs, pulmonary edema. Remember, 2 weeks before he was fine, he has no past medical history. He had an enlarged heart and he had left ventricular hypertrophy. That's actually a red flag because this does not happen quickly. So this young man had some kind of predisposition beforehand. And this is part of the issue, is that he had no significant history. He was not on any medication, and he just presents with this kind of disease. So let's look at a few things about the kidney so that you understand where I'm coming from. So I'll take you through a few slides just so that you can understand my perspective. The first thing is that when COVID infects, if you haven't blocked it in terms of mucosal immunity, you then end up with the virus circulating throughout the bloodstream, brain, heart, kidneys, intestine, blood vessels. And depending on how well and how effective they can put up a fight to this, will determine how long it circulates for. However, for some people, when they get infected, it will trigger an immune response like a lower grade cytokine storm. Doesn't get them dead on intensive care, but it can still do a lot of damage. And you have to remember that within 2 weeks of this infection, he was in hospital with heart failure and kidney failure. When we think of the kidneys, this is essentially what it looks like. So you have a kidney up here, and when we break it right down, you can see that within each kidney, there are these little tufts of blood vessels. These are glomeruli. And this is where all the blood is filtered. And then it goes in these yellow tubes, which will be full of fluid, not urine. And most of it is reabsorbed. And the bit that is passing out here, about 1% of it, will then become urine. So it filters a lot of the fluid that comes through your bloodstream. What you have to notice is that these blood vessels going to these tufts, these are arterioles, small, very small arteries that are then feeding these. This is important because that's where the kidney was affected. It was in smaller arterioles that caused the problem. When we think about how this works, is that he would have had circulation of the virus. The virus would have then triggered an immune response. He would have then had some kind of lower grade cytokine storm, which then causes the immune system to attack not only infected cells, but possibly cells that had ACE2 on them, because he had heart failure, kidney failure that would be very, very suggestive. The other thing I want you to understand is about arteries and arterioles. Now, this is an artery, but an arteriole is much thinner. And what I want you to note is that the lining here, this elastic on the inside, then you have muscle on the outside of it. One of the things that happened is that you had deposition of fibrosis in and around the arterioles going to his kidney. That's important because it gives you an idea of time frame. And this here is an image of what a glomerulus look like, or the nephron. And you can see the little blood vessels coming in. This is where the fluid is passed out, and it then goes into the tubules, and then most of it is reabsorbed. So this is a perfect system, beautiful system, these kidneys, and you want to try and protect them. So within that framework, we then have to think about what is it that happened in his case that caused all of this to happen. Now, you have to know as well that they did a lot of investigations, and essentially they couldn't find any previous issues with regards to his immune system. But his kidney wasn't working, his blood count was very low, as well as his platelets. And this is where that diagnosis of TMA comes in. And I'll show you this in, well, I'll just take it up to the top so that you can see it. Thrombotic microangiopathy. Essentially, they make clots, which then consumes the platelets, so they have low platelets. Then the autoimmune process damages blood cells, so they become anemic, and they have little clots in these capillaries that then damage the blood flow to them. And all of this all happens together, and it was induced by COVID infection. And so what it probably would look like, and I'll get the image up here in terms of the angiopathy, it would probably look something like this, where the immune system is targeting cells around these small blood vessels. So you end up with these thrombi blocking the blood vessels. And so then if you have enough of them, the kidneys are unable to work. Now, this is not just from the COVID infection in the context of what he had. The COVID infection exacerbated it. But there is an important thing that I want to highlight with regards to the biopsy. And so, as I said, we need these biopsies to try and help us to understand exactly what is happening when it comes to the kidneys and so on. This is a scan of his chest, CT scan, and where it shows white is a lot of fluid, and this is showing that it had improved. So this was his heart, his lungs full of fluid, and they had treated him, and then it had improved. His heart was dilated, and again, that had been improved after they had given him some immune suppression. And one of the points that they had in terms of the biopsy, and this is where I said these biopsies are very, very important, and they help us to be able to understand the disease. I'm just trying to find exactly where the pathology is. So in here, we can see that the epithelial cells of the renal tubules were atrophied. So it affected the tubules. They didn't see any platelets or fibrin in the glomeruli. It was mainly small arterial angiopathy and damage to the blood vessels. That was the main problem that they found. There was not a lot of staining for IgG, IgA, and IgM or complement in this glomerular basement membrane. Now, that's important because it then suggests that this immune response was probably cell-mediated. The patient then went on to have dialysis, and he was remaining on dialysis for up to 12 months, I think, after, even with immune suppression. So this actually did quite significant damage in terms of what had happened to him. Um, when we look at the biopsy, so this is what happens when we take histology. You cut through the slices and you can then see in detail what is happening. And so, like, lots of little dots showing cellular infiltration of the immune system around the blood vessels. This is a glomerulus that was thickened. So all of this you can see in detail when you do the biopsy. I suspect that part of the reason why we're not seeing these autopsy studies is because you can't refute it. Once it's seen like that, you can't spin it. You can't say, well, it was something else. I mean, pathology is pretty specific. And so if you are seeing quite specific patterns suggestive of autoimmune responses, there is no way to say that autoimmunity is not happening. And this is why, in my mind, I think that they don't publish autopsies on the vaccinated deaths, especially with COVID, because we need to understand what is going on. How else are we going to know? And the point here in this case is that we are seeing a different kind of pathology when we look at COVID infections in people who have been vaccinated before. I think this is such an important piece of the puzzle, and it really frustrates me that we cannot seem to get these published. I don't know what is going on. I mean, we have thousands of autopsies from the early part of the pandemic. The first autopsy was done in January of 2023 for a patient who died of COVID and was vaccinated. Can you believe that? Subsequent to that, there have been a few scatterings of autopsies, but because I look almost every couple of weeks, I search through all the papers looking for any kind of information about biopsy, histology, autopsy. We are not getting it. An absolute red flag. In case there are any scientists listening, for whatever you may disagree with me about, believe me, I don't think anybody in their right minds, when we're seeing unusual disease presentation, would be able to say there is a good reason why we are not doing autopsies to understand better the pathology going on. Completely unbelievable. And so in this case, at least we have a biopsy to show us what exactly is happening inside the kidneys. He had, there was no platelets or fibrosis, fibrin thrombosis in the glomeruli. The wall of the small arterioles were thickened with mucous edema and endothelial swelling and hyperplasia with segmental onion-like hyperplasia. This is very, very important, this onion-like hyperplasia, because that doesn't happen quickly either. So it suggests that there was a process that was ongoing prior to this person getting another infection of COVID. You could argue whether or not it was from exposure to spike protein from any cause. We don't know. Did he have a prior COVID infection? It is possible. All of this is unknown, but it indicates that his kidneys were primed to respond again when he was exposed to the virus. How many other people do we have like that? It is pretty serious because we still have virus circulating all around. More than ever, as we close out, the most important thing for you to do is to protect your upper airways. Remember, please, please, please hum. That's why we've written Humming Heroes. That's why it's there to help you to understand the science of how to protect yourself with nitric oxide just by singing, humming, doing whatever, just vibrate the upper airways. You need to pass this on to everybody. It's one of the best little books that you can use. You can get a free PDF. Look in the description. make sure you follow that up. Have a great evening.
A hero, an immune adventure. Humming Heroes, your lyrical guide to the body's defenders. Now on Amazon. Check the links below.